All right, today we're stepping into one of the most intense environments in all of medicine, the intensive care unit. It's a world of nonstop monitoring, a flood of complex data, and split-second decisions where the stakes, well, they just don't get any higher.
So I want you to imagine this for a second. You have a patient, they're struggling for every breath. Their oxygen levels are just plummeting, and every second is critical. You have a machine that can save their life, but if you dial in the wrong setting, you could cause permanent lung damage. This isn't some hypothetical question from a textbook. For critical care specialists, this is just another Tuesday.
So how in the world do they make these kinds of impossible choices? Well, in this explainer, we're going to get a look inside the mind of a top expert, Dr. Sumit Ray, to really understand the mental frameworks that guide these life or death decisions, from respiratory failure all the way to septic shock.
So let's kick things off with a true ICU classic, a patient whose breathing is failing, and fast. This is a situation that demands a really careful, step-by-step escalation of care.
Okay, so you almost always start simple, with those little plastic nasal prongs. But if a patient is breathing really hard and fast, they're trying to pull in way more air than those little prongs can deliver. That's when you bring in something called a high-flow nasal cannula, or HFNC. As Dr. Ray explains, it's not just about more oxygen. The high flow of the air actually makes the work of breathing easier. But if that's still not enough, you're facing the biggest decision of all, intubation.
But here's the catch. You can't wait too long. And this is a wild concept. A patient can be so desperate for air, breathing with so much force, that they can literally injure their own lungs. It's a phenomenon called patient self-inflicted lung injury, or PSILI. It's a critical reason why, sometimes, the safest thing to do is to just take over the work of breathing for them.
So when do you make that call? Dr. Ray says he zeroes in on a key number called the PF ratio. Think of it as a scorecard for how well the lungs are getting oxygen into the blood. And for him, there's a clear line. If that score drops below 200 and the patient is clearly getting worse, he says he wouldn't hesitate. You have to act decisively to prevent that PSILI from causing even more damage.
Now, once a patient is on a ventilator, you can't just set it and forget it. It's a constant balancing act. Doctors are tracking a whole bunch of numbers, but Dr. Ray says there's one he really focuses on: driving pressure. So why that one? Because study after study shows it's the number that's most tightly linked with patient survival. It's the cleanest signal of how much strain is on the lungs, and keeping it below 15 is the name of the game.
Okay, let's zoom out now from a single organ to a full-body crisis. We're talking about septic shock. And this isn't just a bad infection. It's an incredibly complex puzzle that involves your entire circulatory system.
What happens in septic shock is that the body's reaction to an infection just goes totally off the rails. It kicks off this massive inflammatory cascade. Your blood vessels dilate and start to leak, and your blood pressure just absolutely crashes. When that happens, your vital organs are starved of oxygen and fuel.
To really get the treatment, you have to think of your circulation in two parts. First, there's the macrocirculation. These are the big highways, your main arteries and veins. We measure this with things like blood pressure. But then there's the microcirculation. These are the tiny local streets, the capillaries that actually deliver oxygen to every single cell. And here's the key. You can have a great blood pressure reading, good traffic on the highways, but have total gridlock on all the local streets.
And this gets us to the absolute core dilemma of treating sepsis. The textbook answer for low blood pressure has always been, give fluids. And sure, a patient might be fluid responsive, meaning their heart pumps a little better with more volume, but in sepsis, their blood vessels are leaky, so they might not be fluid tolerant. All that fluid you're pouring in can just leak right out, flooding the lungs and tissues and causing way more harm than good.
This is exactly why doctors are rethinking the whole more fluid is better approach. Dr. Ray points to this huge study, the Andromeda Shock Trial. It found that when doctors focused on a simple bedside test, capillary refill time, or CRT, they actually gave less fluid and got similar, if not better, outcomes than when they were just chasing a lab number called lactate. It's a real shift toward using simple, direct tools to see what's happening on those local streets.
Now let's talk about a truly terrifying paradox that pushes these principles to their absolute limit: severe dengue fever. As Dr. Ray puts it, if anything scares me in the Indian ICU, it's a severe dengue. Here is the nightmare scenario. Inside the patient's blood vessels, they are profoundly dehydrated, but at the same time, those vessels are leaking like an absolute sieve. It is the ultimate case of being fluid responsive but massively fluid intolerant. Give too little fluid and their circulation just collapses. Give too much and it all pours out, flooding their lungs. So what on earth is the strategy? Dr. Ray lays out a multi-pronged attack. You use standard fluids, but with extreme caution. And you bring in other tools way earlier than you would in normal sepsis. This means using colloids like albumin, which are better at staying inside the vessels, and even considering fresh frozen plasma to try and actually repair that leaky vessel lining. It's a very specialized playbook for a uniquely dangerous disease.
Okay, let's look at another really tricky situation. What happens when a patient who already has a weak heart develops septic shock? In a case like this, the standard protocols can actually be pretty dangerous.
So, the standard sepsis game plan involves giving a lot of fluid right up front. But for a patient with heart failure, their pump is already struggling. It just can't handle all that extra volume. Their fluid tolerance is practically zero. So the entire focus has to shift. You're no longer just trying to fill the tank, you're trying to support a failing engine.
So the strategy gets turned almost completely upside down. You give very little fluid. You start medications called vasopressors, drugs that squeeze the blood vessels to raise pressure, very, very early. And if you do give fluid, it's in tiny, mini challenges, maybe just 100 milliliters, while you are watching the heart's reaction like a hawk with an ultrasound.
For our final challenge, we're going to shift gears from fluids and pressures to medications. And it's a surprisingly complex question. What's the right dose of antibiotics for a patient who's also on continuous dialysis?
You'd think we'd have this figured out by now, but we really don't. The SMART trial, which Dr. Ray called exceptionally well attempted, decided to dig in. They looked at patients on a type of continuous 24/7 dialysis called CRT, which is constantly clearing things out of the blood.
Now, the conventional wisdom for years was, well, dialysis is pulling the drug out of the blood, so you have to give the full dose to make up for it. Seem logical, right? Well, the study found the exact opposite. Giving the full dose often led to drug levels in the body that were way too high, sometimes even reaching toxic levels.
So what's the right answer? Well, the study suggested a simple rule of thumb. For many of these common antibiotics, the right dose is probably closer to 2/3 of the standard dose. It's such a powerful reminder that you have to test even your most basic assumptions with real-world evidence.
So when you pull it all together, what's the ultimate lesson? From breathing and blood pressure to dengue and drug dosing, the theme is always the same. Critical care is not about following a rigid recipe book. It is a dynamic, minute-by-minute balancing act, one that uses the latest evidence to tailor treatment not just to the disease, but to the single, individual patient right in front of you.
And that leaves us with one last big thought to chew on. We are clearly moving away from one-size-fits-all protocols and toward incredibly personalized care. So as our understanding gets deeper and our tools get sharper, are we heading to a future where every single patient in the ICU will essentially get their own unique rulebook, a treatment plan of one?